Let's talk about multiple gestation. The twin rate in 2018 is 3%. The triplet rate in 2018 is 0.1%. Two-thirds of the twins are dizygotic, one-third is monozygotic. In the monozygotic twins, two-thirds are mono-mono, and one-third is mono-di. Really? Monozygotic placentation. The days when the eggs split, so day 2 to 3 is dichorionic, so 2 to 3 is di-di, 3 to 8 is mono-di, 8 to 13 is mono-mono, 13 to 15 is conjoint twins. So 2 to 3, 3 to 8, 8 to 13, 13 to 15. So what are some of the fetal or infant mortality or morbidities? 5 times increase of stillbirth, 7 times increase in neonatal death, mostly due to prematurity. The mean gestation at delivery for single is 38 weeks, for twins is 35 weeks, for triplets is 32 weeks. Less than 34-week delivery for single is 2%, twins is 20%, triplets is 60%. For less than 37-week deliveries, singles is 8%, twins is 60%, and triplets is 98%. Rates of CP for single is 0.2%, for twins is 0.5%, and for triplets is 3%. Infant mortality, single 0.5%, twins 2%, triplets 5%. Twins delivered at less than 32 weeks is 2 times more likely to have high-grade intraventricular hemorrhage and paraventricular leukomalacia compared to singleton of the same age. So, and then prior to 32 weeks, 10% twins, 1.5% singleton. Alright, and then mono versus dichorionic. There's increase in fetal and congenital anomalies, increased prematurity, increased growth restriction, maternal mortality and morbidity. So there's higher hyperemesis, diabetes, hypertension, anemia, hemorrhage, C-section rate, postpartum hysterectomy, postpartum depression. For hypertension, so singleton, there's a 5% chance. For twins, there's 15% chance. For triplets, it's 20% chance. Preeclampsia also occur earlier. less than 35 weeks deliveries, 35% twins and 5% singleton. Placental abruptions, 5% twins, 0.5% singleton. If we do selective reduction from triplet to twins, we can lower pregnancy loss, antenatal complications, preterm birth, low birth weight, cesarean rate, neonatal deaths. When reducing mono, it is recommended that both fetus be reduced. Selective fetal termination is done around 20 weeks, higher risk compared to reduction. This is done earlier. Increased risk for unintended loss rate of healthy fetus is 10% versus 2% when done earlier. Determination of chorionicity. Optimal timing is late first trimester or early second trimester, around 14 weeks. There's the twin peak sign or lambda sign. This is a 25% correct detection rate of chorionicity. For symptomatic women, we can use FFN, even though it has poor positive predictive value. Bed rest, prophylactic tocolysis, prophylactic pessary, and progesterone has not been shown to decrease neonatal mortality or morbidity. Administration of oral beta mimetics increases the maternal cardiac stress, increased GDM, even death, and there's no reduction in preterm birth, low birth weight, or neonatal mortality. Progesterone, there's increased rate of mid-trimester fetal loss in triplets. Tocolytics can be used short-term for antenatal corticosteroids or to transport the patient to a tertiary care facility. Calcium channel blocker or NSAIDs should be first line. Corticosteroids can be given at 22 weeks. We can repeat as early as 7 days if delivery is imminent. Neuroprotection with magnesium sulfate should be given if less than 32 weeks. Antenatal screening, second trimester maternal serum marker screening has a mean detection rate for trisomy 21, 65% in twins, with a false positive rate of 10%. First trimester screening with maternal age nucleotranslucency is serum analyte, 85% detection rate for trisomy 21, 65% for 18, with a false positive rate of 5%. Cell-free DNA has sensitivity to pick up trisomies 21, similar to singleton pregnancies. For the diagnostic test, the CVS has similar pregnancy loss rate of 1% as singleton. And discordance or twin deaths it's diagnosed when 20% of weight difference. There's a 7 times neonatal morbidity if at least one twin is FGR. In the second or third trimester, 5% of twins and 20% of triplets have a death of one or more fetus. After the death of one twin after 14 weeks, the risk of death in co-twin is 15% in monochorionic twins and 5% for dichorionic twins. Neurological abnormalities in the surviving twin is 20% in monochorionic and 1% in dichorionic. Delivery before 34 weeks is not recommended if the remaining twin is okay. Surveillance for twins for multi-gestation, singleton, and twin gestation grow at similar rates until 28 weeks. Every 4-week growth ultrasound if the pregnancy is uncomplicated. Stillbirth rate. Alright, so for di twins, 0.1% at 35 weeks, while the monodi twins is 0.1% at 34 weeks. Di is 0.2% at 36 weeks. For monodi is 0.3% at 35 weeks. Di 0.3% at 37 weeks. Monodi 0.5% at 36 weeks. Di 1% at 38 weeks, and for monodi is 1% at 37 weeks. So weekly surveillance can start at 36 weeks for uncomplicated di twins. Twin transfusion syndrome, 15% occurrence in monochorionic twins. We use the Quintero staging system. There's 5 stages. Stage 1 is just polyhydramnios and oligo. Stage 2, the bladder of the donor is not visible. Stage 3, there is absent or reversal end diastolic velocity on UA in one or both twins. Stage 4 is high drops. Stage 5 is death of one or both twins. Fetal echo should be done for monochorionic twins. Twin transfusion usually is present in the second trimester. We should monitor every 2 weeks starting at 16 weeks. NXT should be done starting at 32 weeks. There's no need for UA Doppler if no discordance. Mono twin, naturally it occurs 1 out of 10,000 pregnancies. The perinatal mortality is 20%. Early inpatient with daily surveillance starting at 28 weeks and deliver by 32 to 34 weeks. Complications include a cardiac twin pregnancy, which occurs in 1% of Momo twins with 50% mortality rate. Conjoint twins is 1 in 50,000 pregnancies. there's only 18% success rate for separation. Timing of twin deliveries, die 38 weeks. If they have FGR or growth discordance greater than 25%, it should be done at 36 weeks. MODI 34 to 37, or basically 38 weeks. MOMO 32 to 34, and they should undergo cesarean to avoid cord entanglement during labor. Triplets, I think this is individualized. 32 weeks plus die twins can deliver vaginally if presenting fetus is vertex. VBAC can still be offered in twins. That's it.